Hello, dear colleagues. Today is 26th of December. National Hospital of the Medical Center of the Presidential Affairs Administration of the Republic of Kazakhstan. Presidential National Center, Almaty City, Kazakhstan. My name is Mynzhylky Berdikhojayev. I'm in the control room now, and my assistant Abzal Jumabekov, he's doing angiography for the patient, 67 years old, young gentleman. He was previously treated at the time of stroke, and we placed cigar stent on the right side. It was a stenosis. Yes, stent is nicely open. It was critical stenosis, and we did angioplasty and stenting for the carotid stenosis, and it was also critical stenosis in vertebro-basilar system. This is left side. On left side, the slight stenosis on carotid, no indication for treatment, the kinking on the both sides. And yes, the left side is okay. And now patient came for the left vertebral V4 and basilar system problems. Okay, let's measure the carotid stenosis on the left side. This is a 4.9 millimeter, and this is approximately 4 millimeter. No indication for the stenting without symptoms, but vascular surgeons might do endarterectomy, but for me, no indication. Okay, let's see AP. Patient is moving all the time. Okay, now absorbed in subclavian artery on the left side, and if you see clearly, there is a markers of credo stent. Patient was previously stented, and there is a basilar aneurysm. The right vertebral artery were occlusion. You can see here. I think this one is more illustrative. This is subocclusion. Yes, and occlusion in V4 segment. I don't think we need to touch this vertebral, but sometimes stenting the V1 segment is very helpful, and is keeping the flow in whole vertebral artery. Abzal is trying to go to the vertebral artery. It's stenotic, and here is the aneurysm. Here is also something. It looks like there is some changes. It might be also aneurysm in vertebral here. Vertebral here. This looks like vertebral, but it was a bifurcation here last time. Okay, I will join the Abzal, and you can see the credo. Credo is here from here to here. It was a subocclusion, and we placed a credo stent. I'll just measure the diameter of basilar artery, 3 millimeter, and here residual stenosis, 40% might be, and this point with aneurysm is 5.6 millimeter. Абзал қой отыр. Мен кірейін. Окей. Зион бере салшы, Зион Blue. Yes, Abzal Jumabekov is assisting me. Somewhat in a green apron. She's just graduated residency in Moscow. And also we have Kamil John from Tajikistan. He decided to stay after discussion neuro course last week to see the cases. Operating nurse today, Aliya Tashpolatna, our chief nurse. Bakhat is anesthesiology nurse and video on company. Presented by the chief Evgeny Grishayev. He made the live streaming possible, huh? And we are working with Evgeny since 2017. Next week, it's 10 years from the opening the neurosurgical department in this hospital. Previously it was Central Clinical Hospital, but now it's changed the title. It's a public hospital. The name is National Hospital in Almaty. The same hospital, just hospital in Astana. Okay. The gentleman under local anesthesia, and we discussed with the Elat Levy from the team of Buffalo. They start to do cases, they start to do treatment under local anesthesia in outpatient hospital. But we are doing it inpatient for a long time, and we discussed about the possibilities of treatment, the challenges of doing all those things under anesthesia local. Okay, as usual there is some problems, huh? Okay. It's a Fubuki 7 French, it's quite soft guiding catheter. Okay, it's a tips and tricks using of Fubuki, Xeon Blue, which is 14 system coronary guide wire we are using for the stenosis, and time to time we are using it for the navigation. And also, if there is no complex anatomy, it's possible to use also for the IC aneurysms. Okay, let's see. This manipulation may create some spasm, and very rare it might end by dissection. That's why we asked to bring the Fubuki catheter. The coronary guidings usually may end with the dissection. They're quite stiff and may end with the dissection. That's why we're working with the Fubuki. Okay. No spasm. Okay. It was a critical stenosis last time, that's why we placed the credo stent, and at the same time it was an aneurysm below. Now we can see there is aneurysm also above. For the aneurysm above, I think we need to place just a stent without coils. What do you think, Abzal? Do we need to use any kind of coils?
I think just stents for both aneurysms.
Just stents, yes? Stent monotherapy.
Yes.
There is a stenosis. It's quite challenging dealing with the patient with stenosis. It's a 3 millimeter. Now it's a stenotic point 1.6 millimeter. .8 millimeter, and here nearly 2.2. I think we don't need to touch this one, and might be we need to angioplasty this one, 1.5. Last time we just placed the credo, 3.4. It was a little bit severe than now. That's a 2 millimeter, and now I think it's also 2 millimeter. You can see this point also. It's nearly 2.4, and this part 5 millimeter. Нейроспид 2,5 бере салшы ташпортына. Бар ма? Нейроспид, жоқ, нейроспид. 2,5. Ага, бере береміз. Элвис өтеді. Өтеді. Ага. Біз, скорее всего, Элвис қоймаймыз ол жерге.
Нейроспид 2,5.
Хотя 2,5 он жеті бар екен ғой, да? 3 тұр шығар, 3,18. 3,18. Okay. Ачерадан көрі Ева дұрыс болады. Ева. The distal part is 3 millimeter. That's why maybe we will place Elvis Evo through the Neyrospid, but the one challenging point will be the aneurysmal part in proximal basilar. It's look like
Индифлятор ашырды.
ашыр? Индифлятор керек жоқ.
Индифлятор керек жоқ.
Қажет емес. Okay. Okay, let's see. It will be a little bit challenging because of the previous stent. Индифлятор керек, проксимальный жағын үрлейміз. I think we need to inflate the proximal stenosis, which is 1.5 here. And the balloon is Neyrospid 2.5 by 8. It was a question from the experts from economy department why we buy Neyrospid balloon. I think it's reasonable from the point of expert from economy department, because it's quite expensive device, and I think I damaged the wire. Okay, let's try. Не наш пояс оснащен на всякий случай. Чекай Black. Дай на пояс оснащен, точно. Yes, it was a question from the expert, financial expert, why we don't buy coronary balloons, why we use this one. From the economical point of view, maybe he is correct. But from the medical point of view, he is not correct. It's different devices and different indication. Yes, I think the same things might happen everywhere, and our colleagues are experiencing the same kind of stupidity. Yes, now we have instability in proximal part, and the fubuki is outside. Yes, it's a negative point of using the fubuki, which is quite soft guiding. It's helping to avoid the dissection, spasm, but it's not helping to avoid the instability in proximal part. There is no space for speed and 35 there. Yes, maybe now is better. Okay. Let's see what we can do. Yes, there's many things we couldn't understand as a physician, and there is also other part of barricade. The economists and lawyers could not understand why we are making decision like this. Why we are making decision like this. It's a system. It's a medical system, and yes, it's a part of life. We need to live in this environment. And there is a tortuosity in proximal vertebral. That's why the neurospit is pushing the fubuki. I hope we can push the guiding catheter as much as possible. Yes. Now it's possible. Why? Because of this anatomy, it's better to put caudal angulation. Because of the keys, it's better to angulate it a little bit like this for the better visualization. Like this, we need to see the proximal part of the distal part of the fubuki. Yes. no collaterals. That's why there is an indication to treat the stenosis again. Yes, it looks like we could pass the stenosis. Okay, and we need to be careful, there is another aneurysm. Huh? Yeah. We should keep in mind there is another aneurysm. Okay. Yes, I think we can see the aneurysmal portion. The patient is moving all the time, no? Okay. It looks like we're inside the aneurysm now. It's better to place in AP. Yes, it looks like we are inside the aneurysm. Okay, let's navigate in AP. AP is better to see the distal aneurysm. Yes, the guide wire during the shaping became like a coil. Okay, it's a 0, 0. We need to see clearly the aneurysmal dilatation. Okay. I think it's inside the aneurysm. Yes, maybe we will need a... Yes, we need a Chikai black. Chikai black. Let's do angioplasty first, before we place Chikai black. Чуть-чуть вперед. Назад. Yes, the positive point of using the credo angioplastica. Earlier. Nominal alt. We'll give 6 atmospheres. The positive point of using the credo stent is a closed cell design, and when you need to cross the stent, it's better. We gave 6 atmospheres, which is nominal pressure. Again, 6 atmosphere, which is also nominal. Yes, it's 6 atmospheres. Назад. Okay. Аға, қимылдамаңыз. Қимылдамай жатыңыз. Қимылдамай жатыңыз, қимылдамаңыз. Yes. The wire directly inside the aneurysm. That's why we'll replace it. Конечно. Ну, опция. Суға салсын. Судың ішіне салсын. Okay. Yes, 2.5 balloon. We prepared the paper about the Credo Hill and the narrow speed balloon, and it was a discussion with Akandi's team. If you inflate 1.5 balloon till 14, it will be 217. 2 millimeter balloon till 14, it will be 256. At 14, the balloon became stronger, and the ability to angioplasty is quite high. And 2.5 balloon at the 14 millimeter will be 3 millimeter. That's why it should be very careful when you overinflating. But in most places, colleagues inflating till the nominal pressure. At the nominal pressure, the narrow speed balloon is quite soft. And if you need a higher ability of angioplasty, if you have vessel 2.2, then it's better 2.2, 2.5, and the stenotic point is critical, then it's better to take balloon 1.5, and you can overinflate and the balloon became more stronger. In coronary balloons, the same situation. It's a semi-compliant, and then if you go to the upper limit, it became non-compliant. It's more stronger. Okay, but in this situation, we need only 2.5 millimeter diameter. That's why we will not overinflate. We will do inflation till the nominal pressure, maybe a little bit high. In the lower part, there is a diameter 3 millimeter, and in upper part, at this point, at mid-basilar, it's like the distal is 3, maybe we'll do 2.5 millimeter inflation before the placement of Elvis Evo stent. It's a dysplastic aneurysm, atherosclerotic aneurysms, and it may rupture. No? It's better to do angioplasty than place the stent. And it's better to place the stent than wait the rupture. Okay, I hope. Ага, қимылдамаңыз. Слишком активно. I think we can place two Elvis Evo stents, one for the distal and one for the proximal. Okay, now we are in the distal anatomy. So it's better to go to the PCA, then it's going directly to the SCA. I need the tip of guide wire inside the PCA. Okay, let's push the. Okay, first of all, we will do once again inflation. Okay. Урлив. Номинально. Екі жағым ғой бұл. Он бересіз. We will give 10 atmospheres. Назад. Осы жерден 11. 10. Stop. We gave 10 atmospheres, and it might be a little bit painful, and patient is feeling the pain. Huh? Okay, назад. Yes. Конча бердің? Yes. Yes. At 10 atmospheres, 2.5 millimeter balloon became 2.8, and the artery is a little bit 3.4 millimeter. This patient is moving. Okay. Smart mask. I don't know why when I'm pushing the pedal, usually it's possible to press the. Okay. Let's look like. Okay, it's better to go to one of the PCAs. Так, мына жерде 6 бері сал. Қазір тұра тұр, 1 секунд. 6. Ташпалатына 3 мм деген нені бере салшы? LV-Sebo. 6. Все, стоп тұр. 3.18. Окей. Just a second. Назад. Окей. Қойып. Аға, қимылдамаңыз. Қимылдамаңыз. For the distal basilar, we ask to give a 3.18 LV-Sebo. Жақсымысыз? Қалайсыз? Амансыз ба? Атыңыз кім? Табанның басын қимылдатыңызшы. Мына табанның басын қимылдатыңыз. Оң аяғыңыз, саусақтарын. Сол аяғыңыз. Хорошо. Өзі әлсіз беді. Сөйлесіп көр.
Бәрі жақсы ма? Үстеге бала. Ал. Қаттайтыңыз. Жоқ. Ал. Қашан салдың? Жаңа салдың қалдың? Атыңыздың атыңызды айтыңыз. Ал.
Okay. Now it's better. There is a slight dysarthria, but it's okay. One more time. Ангиопластика жасаудың қажеті жоқ, да? Okay, let's push a little bit the narrow speed distally. Yes, I couldn't explain to the economical team, for the expert from economy, that it's impossible to take the stent intracranial and place it to the coronary balloon. And now we will place LV-Sebo stent inside the narrow speed. Назад. Да, и терешь. Yeah, okay. Okay, let's see how the LV-Sebo will behave inside the narrow speed. Yesterday we placed, not yesterday, on Wednesday I visited my colleagues in Tashkent and we placed Pegasus stents through the narrow speed balloon in Tashkent, and now we took a LV-Sebo and the pushability, it's smoothly going inside the narrow speed. Usually it might be a problem when you have a LV-Sebo with the echelon. It's a little bit problematic to push the LV-Sebo stent. But through the narrow speed now it's pushable. Okay, let's see how it will be opened. Yeah, this one.
This one, get buddy.
Yes, there is a different tools, different materials, and then we have experts, huh? And they ask why you using so expensive balloon. Okay. They treat nobody, but they're asking very smart questions, huh? Why you are using narrow speed balloon? Okay. Maybe we need to pull the stand a little bit. It's look like it's a little bit distal. I think now maybe it's better. Huh? Yes. The lesson learned from one of the last cases, before the detaching completely the stent, LVCO, we need to little bit push the catheter. If we pull the catheter and keep the negative pressure on the system, then stent may jump proximally. We had one case like this, and we should take out the stent after. That's why now I started to do it in a little bit different manner. After placing the stent, I'm a little bit pushing the system. Okay, minus. Let's see the minus. Okay, the stent is opened. Now we cover the aneurysmal segment. Okay, it's good. It's good. Now we can place the stent. Also, I have quite limited experience using the Elvis Evo stent in ICAT. We did a case in Atrau city, which is in western Kazakhstan, and it was a patient with ICAT, and we had no dedicated stent, and we used Elvis Evo for the angioplasty and stenting. Okay, I'm not sure we need to go distally. There are two markers, marker of the previously placed credo, and the marker of the receiver. Okay, I will pull the delivery system. Oh, there is a problem of this looks like it's stuck inside. Oh, there is a problem. Huh? It's stuck. I don't know why, but it's stuck. The delivery system is stuck. Okay. Maybe we'll change the microcatheter. Now let's do the angioplasty first. It looks like okay. Just a second. I will bring the balloon a little bit proximal. We'll do one more time angioplasty before we'll take out the whole system. Angioplastic. One екі бересіз. Yes, we will give. Stop there. Yes, now we give 12 atmospheres inside the previously placed credo. Назад. Okay, and we need to angioplasty the proximal part. It's impossible. Еще раз, Моника. Twelve atmospheres. Назад. Еще раз, Моника. Назад. Yes, we gave 12 atmospheres and yes, unfortunately the delivery wire of the stent is stuck inside the stop. Good. Okay, the delivery wire is stuck inside the narrow speed. I don't know what happened. Let's see what happened. Balloon is okay, but this system, it's not possible. It's not possible. Abscissal. Okay, now we need to place one more stent in proximal part. Headway on jet very. We'll take headway 17. Yes, but finally it was possible to place a LVCVO through the narrow speed balloon. It's very good point. Huh? Yes, it was very good point. Okay, now we will take a GK Black, and as in previous wire, I think we need to do a little bit pigtail-like tip to cross the aneurysmal point. Torkening güzel. It's not a pigtail, but it's J-shaped. Tartar. Stop. We need to decrease the zoom. And yes, it's a positive point of using something like credo. I didn't cross the Pegasus yet, but maybe in the future it's possible. Just a second. Okay, let's measure the proximal part. Okay, let's measure. At the beginning it was just 1.5. Now it's 2 millimeter. Even we inflated till 3 point something. Okay. It's a 3 millimeter, it's a 3.5 millimeter. And here it's a 3 millimeter. I think the 3.5 millimeter sharp 22 versions. We'll place 3.5 by 22 LVCIVO. I hope it will be okay. Так, гиперинкет той, да? Пациент бриллинтада, да? Yes, patient already on ticagrelor, and we placed carotid stent, credo stent, and he was tested at the first time. В этот раз тоже проверяли, да? Okay. He was tested at first time, that's why this time he wasn't tested. But it's looked like okay. Есть? Сейчас. Интервью. There is a clock on the machine, but it's a little bit non-correct. Now 9:51, and the time shows 8:51. It's not correct. Okay. Қалыңыз қалай деп сұрайсыз?
Қалыңыз қалай? Ал.
Usually patients may tire because of the length of the procedure. Eva is coming. Where is Eva? I think this point might be maybe a little bit proximal. Now I can open the stent. I will push it a little bit. Let's understand. Okay, let's do the minus. Zoom. Right, okay, also. Okay, just a second. I will continue to open the stent with the pressure. There is angulation, no? Okay, there is an angulation. Second, let's give a little bit more angulation to become J shape. Көзім қышып кетті. Yes, now we're inside the stents with no problem. Okay. Сәлеметсіздер қалдырыңызға. Yes. Now we place the LVCVO inside the previous cradle, and it looks like everything is okay. Yeah? As the stance is open. Okay. It's a braided technology, and they will decrease the flow inside the dilatation, and it will help to heal the segments. Okay. Аға, қимылдамаңыз, 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 қимылдамаймыз, қимылдамаймыз, қимылдамаймыз. Бос жата беріңіз. Okay, one more time. Okay, the brain looks clear. Now Abzal will place the light rod. Okay, let's measure the stenotic segment and check the. Okay, the previous one is better. Yes, we placed one LVCVO here. There is a slight stagnation inside the aneurysm. It's a good sign. No need to place a FD. I think LVCVO will change the flow and could stabilize the. It's again 1.6. Huh? It was at the beginning 1.6, and now it's again 1.6. We did angioplasty, but yes, at this point is 2.1. It's nearly 50, less than 50% of atherosclerosis. And distally we also did the angioplasty and placed the LVCVO. Okay, let's do control CT. Келесі пациент келді ғой, де? Yes, the next patient in 20 minutes. Okay. Қалайсыз аға? Аузыңыз кеуіп қалды ма? Диабетіңіз бар ма? Сахар бар да? Қолдарыңыз былай қимылдатыңызшы. Қолдарыңыз қимылдатыңыз. Окей. Аяқтарыңыз былай табандарын бүйтіңіз. Все, жақсы, қазір бітіреміз. Су ішесіз қазір. Okay, patient with diabetes mellitus, that's why he wanna drink water. Bernie. Dear colleagues, CT is ready. You can see the stents in vertebral basilar system. And the brain is clear, there is no complications. Yes, the brain is clear. Now we can finish the case and see you in 20 minutes. Thank you. So.